My topic again is anterior to psoas and lateral ALIF. So as some of you may have seen, in honor of the Olympics here, we've all seen kind of this meme already. And I know naturally I'm following Dr. Pimenta and of course Dr. Turner already. And so if this is me doing lateral surgery, this is Dr. Pimenta doing lateral surgery, right? He helped to essentially invent the entire field. But that being said, hopefully after this talk, many of the residents and fellows in the audience will get a sense that this is very, very doable. Now, interbody fusion, there's ALIF and then there's posterior and there's all these things in the middle. And I always like to say that, if ALIF is like your St. Bernards and your posteriors are like your cute pugs, everything in the lateral are like your pit bulls and your bully breeds, right? They come across with a lot of names, transpsoas, anterior OLIF, XF, DLIF, PTP, laterals, and they may look a little bit different, but they're essentially the same, right? So that's why, I feel a kinship to anyone who does XLIFs or PTPs because we approach it a little bit differently, but it's essentially kind of the same thing, right? And so what I'll be talking today is lateral access. So there's a lot of ways to get to the spine, right? As you can see here with all the LIF monikers. And today I'll be going over anterior to psoas, which is also known as OLIF, trademarked by Medtronic, and then lateral ALIF. So you take this diagram, turn it on its side, and this is what we'll be going over, right? So as an overview, why do I do it? What is it exactly? And then naturally, as a resident and fellows course, how do you do it? And that's what I'm going to be focusing on. So why do I do it? The surgical goals regarding what you do are always going to be the same, right? Decompress, stabilize, and realign. And really, the tools in my toolbox that I like the most, anterior to psoas and lateral ALIF, simply they help me do this, the surgical goals, which essentially help people, they help me do it better. And for these applications, you're able to do lateral access from L1 to S1 with very large footprint cages. So what this means is that first, why I do it, I have consistent dependable access to L4-5 and L5-S1 essentially in every single patient. This also allows me to do single position surgery, lateral decubitus, minimally invasively. And this includes both 4-5 and 5-1, right? So I can do 5-1 in single position. And then this opens up the corridor and the possibilities of MIS deformity surgery. So for these three reasons, we know that for reason one, L4 to S1 is essentially your most important biomechanical level. Over and over, it's been shown that if you don't restore lordosis here, then people fail. In degen, they have adjacent segment need revisions. And in deformity, I mean, this forms your strong foundation and corrects your fractional curve. So this is a very important level. Single position surgery, right? So here at UCSD, we do single position and it's near simultaneous. Because I stand in the front of the patient with ATP and lateral ALIF, I can have an assistant put in screws at the same time. So with this, it is very, very efficient for the degenerative surgeries that I do, whether at 4-5, 5-1, or higher. And then lastly, for my third reason, deformity surgery, right? Because I've access from L1 down to S1, then I can put in all these cages in the same stage setting and then bring them back and do their posterior minimally invasively, right? So ATP and lateral ALIF open up these possibilities. So that's why I do it. Now, what is it exactly? If these are the three reasons why I do it, let me show you what it is with a few case examples. So number 1, 2, and 3, for the first one, a 4-5 anterior to psoas. So here's a patient coming in, very standard degen patient, 4-5 degen spondy. You can also see, though, that they reduce on supine imaging, right? There's that vacuum disc phenomenon that tells you it's mobile. And here is the X-ray, right? So intraoperative X-ray, you see I'm anterior to the psoas, so the retractor bleed is coming in slightly oblique than what you would expect from a direct lateral. You get great restoration of that disc space, reduction of the spondy. This is the incision. So my incisions are about like 4 centimeters, which is just over 2 inches. You can see I'm anterior to the crest. So no matter the crest, I'm doing every single 4-5 level that I do. I don't have to break the bed. These patients are on flat Jacksons. You get an image like this, right? So good reduction of that spondy just with the cage, right? So, I'm not doing any posterior reduction here. Another case looks very similar, right? 4-5 spondy, except this is in a guy who's 6'1", 300 pounds. right? He's got a BMI of like 41, really terrible. I told him to lose weight for a year. He still couldn't do it. I'm a bleeding heart in my clinic, and so I get suckered into doing the surgery anyway. But here you can see same outcome. 4-5 spondy in a very big patient. This is not, I'm going to go back. This is going to be a very miserable day for an open case, an MIST lift, whatever you want to do. It's a pretty miserable case. But for an ATP, the belly falls out of the way. So still very doable. You see, get good radiographic correction of his spondy. So that's first reason for 4-5. Now 5-1. So for 5-1 lateral ALIF, another case, 5-1 disc height collapse. You got pars defects here. Here's the MRI, terrible disc herniation. And the thing is, for 5-1 lateral ALIF, when you take a look at this, I always like showing the fluoro shots. You see the bones move, right? You forget that really you're realigning the spine. And for lateral ALIF to be able to do this, you get in a large cage at 5-1, because your only other option really is a T-lift or a supine ALIF, but you get an incision like this. So because I do my own exposures, exposures are within my control. I don't get those large incisions that some vascular surgeons do if they're complex vascular surgeons like we have here. You get a 2 to 3 inch incision. Another case, right? 5-1 collapsed disc space. You get a terrible disc herniation here, so you want to do something where you put an interbody cage from the front. And again, you see this is the realignment that we're talking about at 5-1, arguably the most important biomechanical level, and you get that movement, right? So with the lateral ALIF, you get the beautiful movement and restoration of 5-1. And again, you get a large cage down at that bottom, small incision, right? This was in a lady who gets like a 6 to 7 centimeter incision that's very cosmetic, and a good outcome, right? Now, single position surgery, both at 4-5 and 5-1. Again, I'll show you something you've seen already, right? Very common. 4-5 spondy, MRI like this. Here's the robot plan. I know later on there's going to be cadaver demonstrations for robot assistant. This is my first fluoroscopy shot, right? So I navigate all of my inner bodies now at 4-5 and above. So this is my fluoroscopy shot. It's already been navigated in. Excellent positioning of the cage. Final X-ray, right? You get a 4-5 cage at this level, and you get reduction of the spondy, restoration of height. You can see actually the improvement in the lordosis there as well, which I didn't measure here. But for single position surgery, this is the time. So procedure start, incision is at 8:49. Procedure end, drapes down 11:08. So for single position surgery at 4-5, I'm doing this in like a little over 2 hours. Now, this also applies to 5-1, right? So you have a 5-1 case here, pars defects causing that spondy. I have my robot plan. And again, you see here as a lateral ALIF, cage goes in, restores the height, posterior height, and lordosis. Here's the incision, right? So again, you have a 2.5 to 3 inch incision. You have a large cage in the front. You have correction of the spondy. You have restoration of lordosis, additional 11 degrees there. But for this case, that ordinarily would be a supine ALIF flip perk screws, doing it in single position lateral, incision is 330, drapes down 542, right? So exceptionally efficient in being able to do something like this in single position. Last case I'll show for single position surgery. This can even apply to larger cases, right? So you have a gentleman like this who's got a very mild, scoliosis, really coming in due to pain on that main curve and the fractional curve. So here's the foraminal stenosis on his right side, foraminal stenosis on his left side of the fractional curve. So in restoring this, he gets a single position surgery. So here's 5-1, here's 4-5, and then here's 3-4 and 2-3. I'm working from the left side on the convexity, right? So he has several small incisions, and then he gets L2 to ilium in single position, right? So this construct is done in single position, right? So that certainly increases a lot of the efficiencies and not having to then flip or stage it. And he gets correction of the concavity of his main curve, correction of his fractional curve, and you can see here on CT, right? Good straightening of the spine. But most importantly, as we know with inner body cages, it restores that indirectly. So you get the foraminal height restored on the main curve, and then the foraminal height restored on the fractional curve. Now, for the third reason why I do these, for MIS deformity, now you're opening up the case to being able to solve problems minimally invasively. So here's a 74-year-old coming in with a 52-degree curve. She's got a mild sagittal malalignment, right? Whatever parameters you want to look at, whether it's mismatch, PT, 4-to-1, LPA, TPA. You can see here a 52-degree curve as well. So the thought here is, well, can I just do this minimally invasively with cages and then correction? And based off of the predictive values that I get, the answer is yes. So I navigate in L1 to S1, right? So with this navigation, all the cages go in. Then I do 5-1 down at the bottom. And you can see 5-1 as a lateral ALIF, you get that restoration there, right? So that's really the beauty of being able to access 5-1 from the front. Put in that bullet cage. She gets an incision here, 3 inches for 4 cages, 2.5 inches at 5-1. Robot plan. Here's the percutaneous robot plan. And again, you see a really bloodless surgery in the placement of screws with robot assistance. That's my PGY2, right? Putting down a T10 to pelvis rod. But the thing is because everything lines up quite well, the rod goes in quite quickly. We do our reduction maneuvers to do a little bit more of derotation, and you get a case like this. She gets cages from L1 to S1 staged, second stage T10 of pelvis. This is circumferential, right? So it's minimally invasive circumferentially, and you get correction of all of her sagittal parameters, which we know helps a lot more in terms of patient outcome, and then restoration of her compensatory manners, maneuvers. Last case on MIS deformity, 73-year-old, quite sick, cardiac stents. He's got ischemic change on his heart, aspirin, Plavix. So for a case like this, I think many people would be able to do this as an open case, right? You just open him up, do whatever you want, osteotomies, whatever cages you want, posterior, anterior, but he's not the healthiest guy. And so the question is, well, with my skill set in lateral access, can this be done minimally invasively with lateral cages? So in this case, he's positioned lateral decubitus, and he ends up getting ACRs at 3.4 and 4.5. So you see here the ACR at L4.5. Once the ALL is released, you see really restoration of that level at 4.5. I go up to 3.4, right? Second ACR cage at 3.4. And the reason why ATP is so intuitive for me is you can see the psoas muscle being reflected back. ALL is released in the front. So for ACRs, this is the retractor system. I'm looking at the ALL, right? So as opposed to how it was originally described, which was a really great way to do it, with the oblique approach, I can see it and then section it. And then, of course, the cage still goes in directly lateral to contralateral, which you can see here. ALL is being released. The psoas muscle is right there, right? So still preserved. And you get great restoration for this skill set. Again, I go down to 5-1 and I give him an ALIF cage. So as opposed to a disc angle that's slightly kyphotic, I break in with the trials, restore that, and you give him a more normal type of 5-1 area. 2-inch incisions kind of across all those levels. Here's the stage X-ray. He gets a minimally invasive plan from L1 down to S2, L1 being up in his prior fusion mass. And this becomes, essentially a circumferential case as well. So he gets a robust construct there, 4 rods. You see all the towers, everything is passed. But for someone who's on aspirin and Plavix and cardiac history, it's a bloodless surgery, right? So you get his AP, right? So he gets a robust construct for all his ACRs, 4 rods, 4 pelvic screws, and really nice realignment of his sagittal parameters, right? So again, no matter what you look at, whether it's mismatch PT, L4 to S1 is now 39 degrees, LPA, TP are all good, SV is good, and again, release of his compensatory maneuver. So those are the examples. Now, for my last section, of course, is how do you do it? I'm very cognizant that this is a resident and fellows course, right? So, it's not just about telling you what it is, but how do you do this? So in this last section is a technique guide. Now, the SSF is excellent is because they record all these. So in case this is going too quickly, you can just, check on YouTube later. They'll have a beautiful video. You can go over it as slowly as you want. The first part is positioning. And in positioning, patient's positioning lateral, you can see here a few things. The blue arrows show where the taping job is, and then you'll see it's very low. The top leg is straight. My tape is at the trochanter, so I can see everything down to the inguinal line, especially if you're doing the lateral ALIF at the same time. For a single position surgery, the patient's positioned all the way to the edge of the bed. Here's another view that's closer up. Here's a top view. You can see the abdomen falls out of the way. So even in big people, the distance to the spine is actually quite short. I don't always use a sticky roll if they're big, because I want that abdomen to fall out of the way. If you're doing single position surgery, this is how my OR is set up. You have the robotic system, the workstation of the robotic system, and then the eyes of that. You have the C-arm fluoro for the registration. you have me standing in the front of the spine, all right? I have a Mayo stand, my assistant has their own Mayo, my tech has their bigger Mayo, and then here's the back table, right? So it's a very busy OR, right? It requires a really big OR, but you're using a lot of technology to essentially do simultaneous surgery, and this is what it looks like again, right? So I'm standing in the front, assistant sitting in the back, and you can see the reasons why I still like lateral decubitus surgery. This is a very comfortable position, right? I'm looking down, very comfortable for my neck. This is for 4-5, and here's for 5-1. I'm sitting for the lateral ALIF, and again, I'm looking straight in front of me, right? So it's a very comfortable seated position to do the lateral ALIF. Now, for the anterior to psoas approach, you have the exposure, discectomy, and closure, right? So what that exposure looks like, you have the patient's body like this. I mark out the iliac crest and the rib, so I have my bearings. If you were to look through the skin, what you know is you have the external obliques, you have the internal obliques, and the transversalis. In underneath all that, you have the retroperitoneal fat and the peritoneum. If you were to sweep that in front, just like any other surgery you do, then you have the psoas and the spine, right? As you get closer, there's the psoas muscle. You see a little bit of the disc space in front. And of course, we know hiding behind the psoas is going to be your lumbar plexus and your nerve roots. So what does this look like if you're doing the ATP approach? You have your markings. Say here's your incision for like a, this would be like a 2-3 or 3-4 level. You make your incision. The first thing you see is the external oblique. You dissect through that until you get through your internals and transversalis. You're in the retroperitoneal space. Sweep that all in front, right? You can put like a little patty or a retractor if you like. After that, just as Dr. Turner mentioned in his PTP, you should feel the psoas and the spine. Here, we're going slightly anterior to the psoas, so you're going right at the anterior border. You drop down your dilators, you dilate it open, you put in your retractor system, and then anterior border of the psoas, you can then sweep that back and you have your disc space, right? So if you were to take a look at that, what that looks like in vivo in a live patient, again, this is marking out the L4-5 disc space. So, I use navigation or the robotic system to confirm that, to save on fluoroscopy. You can see my incision is in front of the crest, right? That's okay. That's what this technique was designed for. So the first thing you do once you make your incision, you go through all the abdominal muscles, sweep in front of the psoas. The arrow is to a retractor blade. Earlier on, if you're doing this, if you can't really see, you can set that so that you can visualize. I don't really do it anymore, but this was certainly helpful in the beginning as I'm starting to do this technique. So that's helpful. You dissect it down, feel the belly of the psoas, sweep everything in front, and then you put down your first dilators. In our case, this is navigated. You put down your retractors, dilators, and you set down your retractor. You see this dilator is at the front border of the psoas. It's coming in at an oblique angle, which is okay. Once you set that down, you put down the retractor, you open up, and you begin your dissection as so. Again, for the oblique approach, the reason why it's not as intuitive is you're coming in at an angle, right? Once you come in at that angle, you can sweep the psoas back to whatever you need. So you still put in, like I still put in 22 and 23 with cages, but they come in directly ceiling to floor once you can see that, right? So the psoas is reflected back. Once you have your exposure, you do your discectomy and graft. You'll notice how all of these retractor systems have an opening posterior to you. The idea is that even though you're coming obliquely, you do what's called the orthogonal maneuver. Uh, you push your tool straight ceiling to floor so that the cage still goes in as a direct lateral cage. So that's what that looks like. You put that cage down, orthogonal maneuver, and then you have an incision that looks like this, right? Here's a short video that just puts together all those screenshots all in one like 10-second video. You can see here navigated identification of the disc space. The dilators go down, right? Once the dilators go down, then the retractor system goes on top of that. You can see I am in front of the iliac crest. I will do every single 4-5 level. I haven't done like a 4-5 TLIF in a very long time because I can do every 4-5 level since the crest doesn't matter. I work in front of the crest. Now, again, one of the things I used to think about is, well, if this is the psoas and they're talking about an anterior to psoas approach, like, am I here? That seems very far away from the spine and very close to the blood vessels, right? In reality, you're at the anterior border of the psoas. So if this is a 4-5 level, you can see the psoas is there. If you take a look at that diagram, this is the retractor system. So you don't have to be in front of the psoas. You can be at the anterior border of the psoas, and that's okay because you're still further away from the lumbar plexus than, say, a direct lateral. I don't stimulate the psoas. I don't do this under neuromonitoring because I'm that far away. I really have no worry about the lumbar plexus. You do your discectomy. You can see the retractor system as it comes on out. That is the anterior border of the psoas, and you leave it all very healthily intact. And then here's your incision. Keeping track of time in my last few minutes, this is the lateral ALIF at 5-1, right? The first thing is patient selection. So there's a lot of things to look at in terms of patient selection, the same thing that the vascular surgeons look at. The most important thing is to make sure that the iliac veins are split. So you all take your boards, you all know that the left common iliac vein is what bleeds. So you take a look, this is what you're looking at, right? You have to make sure that this is split so that you can put in your cage. What you don't want is something that looks like this. On axial imaging, you would see the vein then in front of the spine, and that tells you that you have a low bifurcation. And that's what you want to avoid because then you can't put in your cage. Plus, you're in lateral position. This is a very disorienting orientation. So if you want to do lateral ALIFs, set yourself up. This is the MRI here, and you can see here, I'm going to put my laser pointer. This is the left common, right? You have a very wide split here for your cage, very wide split in another MRI, a very wide split here. What you don't want is something like this, right? The vein is coming right at the front of the spine. This is going to take a lot more dissection. I still did lateral ALIFs in these cases, but this was like my 20th or 25th case because it requires a lot more dissection. This is something where you can't even do, right? The bifurcation is too low at 5-1. So again, you can see the positioning is the same, right? You can see down here, I've exposed down to the inguinal line so that you can be sure that you have the the surgical field that you need. Once everything is draped, these are the things that you mark. L5S1 disc space, that's your sacral slope, perpendicular line. You want to make your incision somewhere in between there in front of the ASIS. You open up the skin, the first thing you see is the external oblique. We know that anatomically, right? You take a look in the lower left-hand corner. Once you pass through the abdominal wall, the first thing you see is retroperitoneal fat. When you see that fat, go upwards, find the psoas, right? This is why the lateral ALIF approach is so intuitive for um, the anterior to psoas, right? Because we see the psoas all the time. Once you find that psoas, the next thing that's on the landmark is left common iliac artery, left common iliac vein. It's exactly like an ACDF. When you do your ACDFs, the first thing you feel is the carotid, and then you go medial to the carotid. This is what it looks like. Now, naturally, for any spine surgeon, seeing something pulsating in your wound is not necessarily something that we look forward to or kind of plan our day around. But this is what it looks like. And again, similar to the carotid, we go by the carotid every single day for an ACDF. For lateral ALIF, it's the same. This helps to keep you on track. Because if you know that this is what you're seeing, when you go medial to that, you find the disc space. This is what it looks like in your field. There's the anterior 5-1 disc space, all exposed, right? A really nice exposure from the front. You find your S1 promontory, it's a 6 centimeter incision. You do your discectomy, put in your cage, remove the retractors, close your fascia, and you have your final incision that's what, like 3 inches. Okay. In Yes, sorry, I heard something, but in conclusion.
I think we've lost the. We're not seeing you right now, or your slides, but that's okay. I think we're pretty much close to the conclusion, right? Right, Martin?
Yeah, we're right at the conclusion here. So, for the procedural applications, there are these are the benefits on kind of why I do them, but there are downsides, right? Naturally, there's a learning curve. There's lateral positioning, which is not as intuitive as you're prone, and then there's the complication profile, right? You have to deal with all the complications in lateral or anterior surgery that you wouldn't if you're just doing posterior surgery. So there are pros and cons to all approaches. I challenge anyone to say that there's like a perfect, inner body approach. And so in this way, right, you're all residents and fellows in there. You were born, you're a toddler, you're a teenager, now you're a resident fellow, and you have the opportunity to pick what you want to do. I know how to do all of these, right? I know how to do direct laterals for lateral corpectomies and PTP and TLIF, but you can choose to spend your time learning one thing that you really want to be good at. Ultimately, the goals are the same, right? So whatever inner body you want to do, it's going to be your outcomes and how you accomplish them. So in this case, the world's your oyster and you can do whatever inner body fusion you want. This is, of course, how I do mine, anterior to psoas and lateral ALIF. Um, so thank you for that whirlwind through this.
All right, great. Those are some nice cases. We're a little bit behind schedule, but maybe one question if somebody has one question. Okay, go ahead. Yeah.
I'm Felicia. I'm a 3.5 at Brown Neurosurgery. I was curious if I assume you're no longer limited now.
You all not heard me. So can you say it again? Let me
Was this-
start
oh,
from a new,
wonderful.
here, get your microphone.
Thank you. I'm Felicia. I'm a PGY5 at Brown Neurosurgery. I was curious, I presume you are now no longer limited by the pubic symphysis for your 5-1 access, and if therefore you're able to address high-grade spondies at 5-1 using the lateral technique.
Yeah, so for 5-1 in the lateral technique, the pubic symphysis, sacral slope, and pelvic incidence will still apply. So that means that for a pelvic incidence of 65 to 70, it's still going to be challenging. You'll just have to position the patient, as you saw in some of the positioning diagrams. You just have to be able to free this space right here, right? Because if you're doing a PI, and I've done PIs of up to 85, which is very, very high, I'm way down in the groin, right? So I mark out their inguinal line, and my incision is very close to it. The abdomen ends there, but you still will need special instruments. So it's still going to be difficult. It's really no different than if you do it supine, except if you do it supine, it's your vascular surgeon who will struggle. If you do this, it'll be you who struggles. So kind of your choice of poison. But it doesn't change, right? So if you have a PI of 65 to 70 or higher, you really have to plan your exposure. And what ends up happening is this tape ends up being even lower so that I can see upwards as best I can.
Great. Thank you so much.
Great. Okay, our next